Oh, hey, Chris.
Hey Chuck, how are you?
I'm happy to be back at it. How are you?
I am happy. I'm excited. We did congenital, we did sports. What's going to be next? It's a broad world we live in with hand surgery.
Is it though? Are you just hoping it's nerve again? You hoping we're
Oh,
going back to the
always,
well?
always. And we're gonna get into the what's new in hand surgery 2022, which I'm happy and sad to say I did not author this year.
You're happy. You're happy to say it. You did 3 years. You did a great job, and you handed it off.
But you know what I'm sad about is I did not have the foresight like the subsequent section editor Deb Bohn did to have a resident helper.
Yes, and not just any resident, we might add.
That's right. Kelsey Wise, who's going to be joining us as our hand and upper extremity fellow here at WashU in August of 2022. So in just probably 6 short months, she'll be here with us. So shout out to Kelsey. Great article. Deb, great job on summarizing a ton of literature. I don't think I ever hit this many citations. 109. Very
Yeah.
impressive.
It's impressive. I think I mentioned, but in case I didn't, I do this every year for congenital only. And we do it to award the Paul Mansky Congenital Hand Best, the Congenital Best Manuscript. And it's a labor of love. It's really helpful to remind me of what's out there because I don't read every journal every month. And so I know you felt that way when you did this work, but it's not easy to stay up to date on the literature without some comprehensive looks occasionally.
Yeah, no, honestly, I felt a bit out of touch, not doing it this year. So it's great to read it. I'm also happy I didn't have to spend I can't count the number of hours doing it, but I am a little sad about it. So yeah, we'll spend the next 2 weeks talking about this article. But Chuck, I think probably recently one of the greatest days of hand surgery I have ever had.
And that means it wasn't all nerve.
No, it was literally. So I'm actually going to bring it up in I'm giving the fellowship kind of nuts and bolts talk, and I'm going to talk about how we do a lot of bread and butter hand surgery here on top of our individual niches. Like mine is the peripheral nerve stuff, yours being the congenital and the sports, but each of us has a really busy general hand surgery practice. And it was a great day. It was Cmc arthroplasty. It was, carpals, triggers. It was repairing a lacerated dorsocutaneous ulnar nerve. It was anti-claw tendon transfers. It was disc radius fracture, tendon reconstruction. It was like one of the best lists that I think I have ever had. And that was followed by a day of doing a tendon transfer, nerve reconstruction the following day, and then a plexus. So it was a fun week for
That
sure.
that is good stuff. And it's no having a hugely busy, diverse week of cases is something special. I want to know more about this tendon transfer, the anti-claw.
Well, one of the things that we started doing based on fellow feedback was to do a surgical technique lab. So mixing up our standard anatomy cycle with, fellow selected cases and attending would take them through how they would do a specific type of surgery. So Dr. Lindley Wall was kind enough to be our first faculty to step in, and we talked about different tendon transfers. She did some median to radial, or excuse me, the standard suite of radial nerve tendon transfers used to treat a radial nerve palsy. And then she also showed some static and dynamic anti-claw tendon transfers. So in the lab, we actually did a Stiles-Bonnell, and lo and behold, the following day, we were doing Stiles-Bonnell tendon transfers. And this was interesting because it was a patient with advanced ulnar neuropathy, compressive neuropathy, who I had tried a supercharge on and had some improvement both on clinical exam and objectively on nerve studies at the 1 year mark, but it wasn't enough. And he very clearly and plainly said to me, if I could get my finger straighter here, and if my finger didn't drift out, so the Wartenberg deformity where the small finger goes away from the ring finger, it would help me at work. And he's a manual laborer kind of guy. And I think it just high level philosophically, as a generation of surgeons that's trained with nerve transfers being one of the first things you think about, I think we're a little more hesitant to offer tendon transfers from the get-go. And even offer tendon transfers in the time where we're not seeing our nerve transfer give the result that we want. So it was humbling to see that I had not gotten the result that I was hoping to get, but it was also affirming to know that there were some other options, and it was time to just kind of say call a spade and make the next decision.
So good stuff. I mean, really lots to unpack and not to belabor it, but two things I want to ask of you.
Of course, it's going to be two, of course.
This is always two things. The first is, I think the audience needs to understand what you mean by a Stiles-Bunnell transfer. And was there clawing as the primary complaint, or abduction of the little finger, or both? And maybe describe what you mean by clawing, just to be very specific.
Yeah, so it was both. So the deformity you see is MP hyperextension, and then inability to fully extend the PIP and DIP joint of the ring and small finger. And that is because of the lack of the ulnar innervated lumbricals, which flex the MP joint again. So now the MP joint's an extension. And then the lack of the ulnar innervated interossei, which will help to extend the IP joints and the DIP joints. And the reason this deformity is accentuated is because the radial nerve and its EDC is intact, and it's going to draw those MP joints into hyperextension. So there are a couple of different ways you could treat those that deformity. And there is a great review article written in the old Journal of the American Society for Surgery of the Hand, before it was the JHS was the Journal of the Hand Society. And it was written by a young Chuck Goldfarb and Peter Stern. And I love that review article because it goes through all of the different, it's a great article. And it's in kind of the rotation reading that I assign. And it's great because it really spells out all the components that go into a claw deformity, and has great physical exam pearls. So if you're looking for a great article, Chuck will put that into the show notes.
If I can find it.
Citing himself or me citing him, and he'll include it. But it's a great article. But anyway, so there are different ways you can treat the clawing deformity. And maybe this is an episode in and of itself, but there are a couple of ways to treat it. You can either statically treat it by using some kind of tether to keep the MP joints in flexion. That's been described either through intentional bowstringing of the A1 and A2 pulleys, or advancing the volar plate and doing a capsulodesis of the MP joint capsule so that it stays stuck in flexion. Or you can take a loop of the FDS and cut it distally and sew it back to itself, often attributed to Zancoli, so a lasso kind of procedure. And that's great in terms of keeping the MP joints down. Now, if you are flexing them down and they aren't able to fully extend there, you can consider also a Stiles-Bunnell transfer, some kind of dynamic transfer. And you can either use the FDS to the ring, or you can use the FDS to the middle. And in this patient, we chose to use the FDS to the middle, cut the FDS distally, brought it back proximally, split it in half, and then passed it through the lumbrical canals.
Wow. What's interesting is this used to be, taking care of rheumatoid patients and dealing with patients that needed tendon transfers, whether it be from polio or whatever, was a big part of a hand surgeon practice. And those two things just don't happen very much. And so there are no experts who have done a ton of these anymore. And so it makes it more important that preparation, getting in the lab, doing the right reading, and really trying to get this right. But it's a fascinating evolution of our field.
Well, I kind of honestly, I kind of worry that our trainees aren't seeing enough tendon transfers, to just the point that you stated. And you are less likely to offer something if you are less familiar with how to do it. Now, we can all clearly read about it, watch videos, practice it in the lab. But if you haven't done it in training, you haven't seen the results in training, it's like learning a whole new procedure. And it's weird because it's a procedure that's been around for over 100 years. So it's interesting how things ebb and flow. And I think that we as educators, and I as a nerve surgeon, have a responsibility to know how to do these alternative techniques, because the nerve isn't always going to work out, or the patients are going to come to you too late if they've had treatment elsewhere, or it's been unrecognized. And we have to show our fellows to do these tendon transfers. I didn't see much in my training, along the way. And it was something that I had to go seek and kind of learn on my own. Some of us, I think, have done them more. I know Marty's done a fair bit of tendon transfers, and so have you. They just didn't follow my rotation, which is kind of the nature of the beast.
Yeah, and we try to, in these situations when this this procedure that you did might happen a couple of times over the course of the year. Again, depending on luck of the draw. And so that becomes a case where we want as many of the fellows to see as possible.
Right, absolutely. Well, it was great because, the continuity of going from the lab, being with our resident who was with me, and then doing it and seeing it, in the, obviously doing the surgery was great. Continuity is wonderful. It was probably the best possible educational setup.
Love it. Love it. All right. We got some hand updates to go through.
Yeah, one thing I want to point out, okay? So this is written by Deb Bohn, who does a lot of pediatric and congenital hand surgery. And last year you were giving me hell about not having a congenital section. There is no congenital section. So Deb, what gives?
But there is a pediatric section. At least there's something.
Yeah. And I will say the peripheral nerve section seems to be substantially shorter than the last 3 years. It is 2 paragraphs.
Yeah, and it's right at the end, y'all. It's just trying to compensate for the over emphasis the last few years.
Right. So they led off with carpal tunnel syndrome. So it's super interesting. I think the article that I was attracted to the most, they talk a little bit about diagnostic ultrasound versus CTS6 versus nerve studies. But the thing that caught my eye was actually the randomized study that they cited, looking at injections versus night splinting. We oftentimes see injections versus surgery, and I think you and I have talked about that article in the past. But injection versus night splitting, is that ever something that you've considered?
Meaning, do I consider one versus the other for my patients?
Because I usually start with bracing, and injection comes in after they've failed bracing.
That's exactly right. For me, it's a latter approach, and but some patients, many patients actually, to be fair, which is a compliment to the primary care physicians in our community, many patients come in having already done the brace, which takes them one step up the ladder. But for me, I agree with you completely. It's brace first, especially in the mild carpal tunnel, and see what happens, and then consider an injection with all the pros and cons.
So does this finding that they randomized 100 patients, and they saw 95 to follow up, and they either went to a night splint or to a corticosteroid injection, and those who had an injection had a superior relief of their nocturnal paresthesias and pain, as well as improvements on their Boston carpal tunnel questionnaire at 1, 3, and 6 months. Does this make you think of maybe offering an injection earlier?
No. I mean, I think it's really good information, and it may help a patient who is on the fence about whether or not to accept an injection to get one. But what's missing is what happens if to me, it's the year, because we have data on splints of the year. We have some mediocre data, to be honest, about the success of injections of the year. But if my patients aren't looking for a temporary fix, and I do think for some patients, the splint, it really mild early carpal tunnel can be, I feel like, treated with a splint, while granted most are not successfully treated long-term with the splint, but an injection is rarely the answer for me long-term.
It's you encouraged us to read an article from JAMA Open, like Open Network JAMA, for our journal club a couple of months ago. And it was looking at randomized trial of injection versus at 2 different doses versus surgery. And looking at the longer results. And I'm thankful that you made us read that, because it gave really useful information. The fact that, it's interesting the way that the authors cited that there was significantly less surgery or significant improvement in the symptoms in the patients who had an injection compared to those who had surgery. But what I thought was interesting was that 85% of those who had an injection ended up having surgery at 1 year. So it really is just kicking the can down the road. Now, clearly, as a hand surgeon, maybe I'm biased towards the fact that I can offer a surgery. And if they had seen primary care physician, a physiatrist, a neurologist who may feel more comfortable with an injection versus surgery, the treatment algorithm may be different because the treatment options are different.
Yeah, I think probably some of the listeners are thinking to themselves, I don't see this patient who hasn't tried a splint, who hasn't tried an injection, because some of us have practices where there's a nurse practitioner or a primary care physician associated, and those steps are taken before they walk into the hand surgeon's office. you and I, for better or worse, and maybe eventually it'll evolve as all of medicine probably should. I don't want to become a technician. I like this interchange and making a patient-centered decision. But for you and I, we see patients at all points along the treatment path. And so, like you, I like splints. Injections are fine, but my patients, and I believe I try to give an open-ended offer of an injection. I don't mind doing an injection. There's no skin off my back, so to speak, but most don't choose that.
And we must remember that not all injections into the carpal tunnel end up in the carpal tunnel. And that's what David Green showed. And that was an article that I pulled into one of the prior editions of What's New in Hand Surgery.
That's right. No, that's exactly right. It's an important point. Your ultrasound would help with that, but not all of us will be using ultrasound.
That's right. And maybe you don't have to, but I think it's just being aware of just being super cognizant of the fact that you need to know exactly where you are and where you need to be. So what an interesting study they did here, which I would not have thought of to do, is there was an article out of the European Journal in which they numbed the digital nerves to the thumb and found that decreased dexterity as they measured it, and also numbed the digital nerves to the index and middle finger and found that affected grip and chuck pinch strength, suggesting that the numbness in these distributions would be the reasons why patients with carpal tunnel syndrome, perhaps even without thenar compromise, have decreased dexterity and strength. Does that match your practice for patients who maybe have mild or moderate stage carpal tunnel to have decreased grip and strength?
Yeah, I think it makes sense because most patients that we see do not have thenar atrophy, or at least visible thenar atrophy. And I really do question patients about the buttoning of buttons and the dexterity. And they often complain of strength issues, but if you get them to use the dynamometer, they test okay. But I think this feels accurate. It's super interesting. I wouldn't have thought to do this either. And I think it's interesting. I think it's accurate.
One thing that has come up a lot in the kind of the lay popular culture is the connection between carpal tunnel and work. And you remember in the 90s, there were all the ergonomic keyboards and the big deal about repetitive typing and also vibration exposure. And there's an article in here that looking at vibration exposure and potential impact on outcomes. As somebody who trained in that era, and I'm not saying this in a joking way, but honestly, as somebody who trained through that, what are your thoughts about work-related carpal tunnel and occupational exposure, and perhaps how this article might have, changed that?
For a while, there was a very strong sense that work, especially sedentary work on the keyboard, doesn't contribute. And then some studies have suggested otherwise, and and the AAOS guidelines have tried to tackle this with mixed results, to be honest with you, simply based on the quality of the literature. This obviously doesn't get to the etiology of, as they call it, hand-arm vibration exposure, but it does get to the point that they might do more poorly in an outcome. And so maybe it's not simply that they're work comp patients, maybe it's the nature of their exposure and the quote unquote trauma to the nerve that leads to, decreased, outcomes. And this was a well done study using pretty reasonable outcome measures.
Is it the vibration exposure, or is it the position of the hand and the wrist during the vibration exposures? Meaning if you're holding something like a jackhammer, you're probably gripping it pretty heavy, your wrist is cocked back, and you're flexing through your extrinsic finger flexors. Is that contributing too?
I think if you are ergonomically, I think you can get this. First of all, this is a hard one to define, right? But I think you can be exposed to vibration in an ergonomically okay position without that wrist extension and forceful grip, or you can be exposed in a pretty good position with the wrist locked in neutral. So I have a hard time honestly answering that question, but I would expect in most patients, you're right, it's a combination.
And I know this isn't in this year's article, but what are your thoughts about the keyboarding and the typing? And again, to me, it mechanically or mechanistically kind of makes sense. If you're poor ergonomically and your wrist is cocked back in front of your keyboard, you're already in wrist extension. We know it's increasing the pressure in your carpal tunnel, and then you have repetitive long flexion activity of your fingers. again, that makes sense to me to put pressure on that median nerve.
You know, it's interesting. This is obviously a huge topic. Susan McKinnon at our institution was involved with, I believe it was one of the original reports from NIOSH, looking at the role of kind of repetitive typing in the development of carpal tunnel. And as I mentioned before, it's gone around and round. And what's been really fun, I guess I put that in quotes, to watch is in the worker population, the work comp administrators will send patients these very detailed tests that assess their keystroke analysis test. And they will say, this person does X number of strokes per minute over an 8 or 10 hour day. And they give you these numbers, and there's like these bars. And if you are over 60,000 keystrokes, then, oh my God, you're at high risk for carpal tunnel. And if, you know, it's just, they're trying to be very rigid with the science. And I just think that's silly. So I think you're right. I think it, you know, positionally getting the wrist in the right position matters. I think it's really hard to know this for sure, but I think in some patients with high level exposure, yes, they can develop carpal tunnel related to work. But what it really gets back to, not to get on the tangent, is the laws of each state, right? I mean, we've talked about this. Missouri and Illinois, two states where we treat patients frequently, have completely different rules, whether the work injury must simply contribute or whether the work injury has to be the predominant cause. And those are light years different.
And this is why so many people don't like to take work comp. But you're also listening to two guys who take work comp. So
yeah, it's super interesting. And that's where there's 3-day courses on it.
yeah, exactly. So we talked a little bit about different carpal tunnel release techniques in our last week's episode, and you talked about wanting to use this carpal clip, and I talked about potentially wanting to use ultrasound guidance. But the standard for both of us is to do a mini open carpal tunnel release. And the challenge with, I think, newer technologies is that it would add a lot of cost. And there's an article here that was a multi-state administrative database study that looked at over 500,000 patients and showed that about 1 out of 5 had an endoscopic carpal tunnel release versus an open release. Supposedly based on, I mean, complications is tough to measure in administrative data sets, but you know, no difference in the rate of complications. Growing use of endoscopic threefold over the study period of 15 years. The cost was $2,000 more per patient. How do you feel about that?
So it is an interesting study. And I guess I'll start with the complications issue, which again, like you said, is hard to document with this type of database. What's interesting though, is that I think a very experienced person using endoscopic, when compared to a very experienced person using a mini open technique, likely have very similar outcomes. It's the people who do far fewer carpal tunnel releases. I think in those hands, endoscopic is not as safe. I really just don't think it is. There's no question that a mini open release gives you a great, reliable result. The surgeon doesn't really have to stress in the OR. It's a reliable, 10-minute procedure, and patients will do well. But pillar pain is real, and it does delay back to work. And so, is the slightly higher expense at the time of surgery while doing an endoscopic procedure worth it? I think the financial assessments of this would say yes. If you look at cost to society, it's absolutely worth it in those patients who need a rapid return to work to consider endoscopic.
So $2,000 versus getting somebody back to work, maybe 7 to 10 days, even 14 days faster. From a societal perspective, that does make sense that it would be worth it. But unfortunately, we don't always have a societal perspective.
No, we don't. And sometimes we have a very personal perspective that the surgeon's going to look. The surgeon, let's just be very honest here. The surgeon fee, that doesn't mean surgeon reimbursement necessarily, but the surgeon fee is higher for endoscopic, and the center collects a higher reimbursement as well from charging for an endoscopic procedure. So there's all kind of misaligned interest here, which ultimately our health system needs to figure out.
You can be in charge of figuring that out. You're a very good leader and administrator. I look forward to seeing what's next on your docket.
I'll get right on that.
Now they've moved on in this carpal tunnel section to close with a landmark article by Velicki et al. Second author, none other than the man, the hammer, the workman with his hammer, just looking for nails, Chuck Goldfarb, talking about carpal tunnel release in pediatric and adolescent patients. So what was your experience with this article? Now we've got the insider scoop here.
Well, Catherine Velicki did a great job. She is in orthopedic residency now. She was a fourth-year medical student previously. And, Lindley Wall and I certainly treat our fair share of pediatric and adolescent patients with a variety of issues. And the literature is really limited. We are trying to make a small contribution to that literature. And I think the findings feel good in the sense that they feel accurate. You can do these analyses and you walk away thinking, does this help anyone? I think it does. Clearly post-trauma acute etiology, carpal tunnel release should be utilized and should be expected to provide a good result. And if you have a tumorous etiology, and often for us, maybe that means macrodactyly or something putting direct pressure on the nerve, then those patients do well. Other etiologies where you're seeing a patient much later, months and months after a trauma, if you have some unusual genetic condition, the expectations need to be tempered. And that's the message. Not that it's not appropriate to do the surgery in those cases, just the expectations should not be the same.
It's interesting how different our practices are, because I typically think of myself as a nerve person, but I remember one time you were out of town and I saw one of your patients who was having wanted to come in. And it was an adolescent patient with a lysosomal storage disease. You had done a carpal tunnel. And I was like, I had never even thought about this. It's just because of the way that our practice patterns are, that stuff obviously, and rightfully so, goes to you and Lindley. And it's something that I had never thought about.
It's interesting that, that's what I like, right? I mean, as you and I have talked about, and we've said on this program, we all have good bread and butter practices, but our niches are strong. And that's why, we refer internally. And I think it helps us provide the best care for the patient.
So that was a fantastic contribution to the literature. And Kat is now, no, seriously, Kat is now a resident at OHSU. And she is actually just got an article accepted for her Wide Awake, not her Wide Awake, for the local only hand pack, the environmentally friendly hand pack. So shout out to Kat.
Yeah, she did a great job, and she's going to do great things. And as you know, I adopted your and her environmentally friendly, very limited hand pack, and I like it. So I appreciate that contribution as well.
Call it the Cat Pack. Cat Pack is going strong in Chesterfield and at South County. So they moved on to thumb Cmc arthritis. There was a really interesting article here that I thought was matched my practice. So I came out in practice, and my first, I think, year, like a board collection, I was curious because I didn't have any thumb Cmc surgeries. And that continued into my second year. I didn't do any thumb Cmc surgeries, but I was seeing the patients. I was injecting them. And I don't think I'm gun shy to offer surgery when I think it's the right time. But these three studies that they talked about here matched it. So they looked at patients who had a thumb Cmc injection, and the three rates that they said the patients who had surgery after injection was 12%, 13%, and 9%. Do you think does that feel right to you?
It does not feel accurate, but I can't argue with this. And then you get into the question of, did the injection, are we just treating arthritic flares and we get the patient over the flare and it burns out? Are some of these patients going to therapy? I guess part of what you said, though, rings true. You develop a large enough base of patients that are being treated with injections, and they do come back. There clearly is a group that comes back regularly and is fine with injections. There's a group of patients that you inject, you go away and may never see them again, or it may take more than 5 years. And there's a group of patients that just aren't interested in repetitive injections, and one injection makes them better, but that's it. So it's super interesting, and it's pretty compelling.
These numbers feel right to me. I'll be very honest with you. Now I do a fair bit, not a fair bit, I do some thumb CMC surgery, certainly more than I did early on, just because the patients, I've developed a relationship. They come in, they've kind of run their course with the injections, and they decide they want to move forward. We'll never know the patients who don't come back, whether they see somebody else and end up having surgery, or they just decide it is what it is with their thumb. But I think one of their conclusions here was talking about the influence of surgeon attitudes towards treatment, and the interchange we're having right now reflects the lack of agreement on perhaps when to pull the trigger for surgery. And it is all about how, and I don't want to say this the wrong way because we're not selling surgery, but it is kind of how you frame the discussion. When you talk to patients about what the recovery is going to be like and what to expect from it.
Yeah, you're certainly right. And we can talk about scripting this more. I really feel like I'm neutral for all patients. I probably am not. Like a third party might listen to my spiel and say, "Oh my God, you're the surgeon. You don't even know it, and you're pushing these patients towards surgery." I don't think so, but who knows?
Well, one thing that has informed and perhaps skewed how I talk to patients is a study that we did with former fellow Jeff Steppen, and Jeff's been on the program a couple of times, and Jeff did a qualitative study at looking at patients' experiences after this kind of surgery, after a thumb CMC surgery, and oftentimes we don't tell them how long it's really going to take to get over this surgery. And I've certainly shifted my time frame to be longer based on the results of that. And also that's informed by literature. One of the other studies in this section talks about the time to return to work after a thumb CMC surgery being 3.5 months. And that feels about right. And, in terms of returning to activities where you're no longer cursing your surgeon's name or thinking about your surgeon, that probably is beyond 6 months. And once I tell people that, you can kind of see the air go out of the room. And they're like, "Oh, I don't want to wait that long." But you do have to balance that with saying you get great pain relief from this surgery even early on when you're not using your thumb right away.
Right. And you're 100% correct. And it's a little bit of a danger with this procedure that we at WashU have taken to be a step up, which is using using artificial internal brace, so to speak, or what's it called? Suture.
The generic term is the suture tape.
Suture tape. Yes, generic term.
I could see those wheels turning.
I couldn't pull it in. That's what happens when you pass 50, Chris. And I mean, because the return to work is faster and the return to life is faster. So, but I think you're still right. I think even those patients are not, quickly great. What's interesting though, in the same article, they discuss timing of surgery relative to onset of symptoms, which then makes this even more of a quandary if you believe the results. They looked at, Espaka et al. Looked at 121 CMC joints treated with LRTI, and they found that postoperative quick dash, now quick dash is not the best metric in my mind, but it is a metric. Those patients who had surgery at less than 2 years after symptom onset versus more than 2 years after symptom onset had a significantly higher improvement in their quick dash score. So earlier surgery is better outcome, but yet we're not pushing surgery.
But I would insert some input, perhaps from the David Ringian side of things. And what about their coping mechanisms? Is there something about those patients that are better equipped to deal with surgery, or is there something about their personality that leads them more towards surgery? And what we'll never know, but how did their surgeon talk to them about the surgery?
That's exactly right. And we have our own surgeon, Dr. Ryan Calfee, who's going down that garden path towards understanding these variables and the role of anxiety and depression and outcomes. And David Ring was certainly, to my knowledge, the first and certainly the loudest proponent of the psychological components of health and impact on hand surgery. And he's certainly not the only voice anymore.
It's interesting for thumb CMC patients. They spend so much time with our therapy colleagues that I really trust that our therapists to talk to them about kind of what comes in, what surgery entails, what that recovery is like. And that oftentimes I think will kind of make the patients feel at ease with the decision that they come to, if not also informing the decision that they come to.
I totally agree. So listen, I would vote we'll stop here and come back and hit the rest of the articles, mainly focus on wrist trauma, and then there's a couple other topics, if that sounds okay to you.
Sounds okay. I'm really excited about the pediatric fracture section coming up.
Well, hold your horses, as my mom used to say. We will get there and we will dive deep.
Sounds good. Hey, you got to give me a win.
Okay, I've got one. So Saturday, the 12th of February marks my third child's ACT exam. So she just got home and took the ACT. And we're in a really happy place. It's that joyous time between taking and receiving one score, and it's all optimism. It's like the beginning of baseball season.
In 2022, how long does it take to get your ACT score back?
Well, first you got to recover from filling in all the bubbles.
Right. They haven't exerted that effort before.
I think it's a month. I think it's a month.
Wow, that's crazy still. Huh.
Isn't it crazy? And some of it's the psychometric evaluation of the exam, I'm sure, and all that kind of stuff. But it's just a happy time in the household, and that's the win.
Well, that is wonderful. I still remember, taking different exams at Prometric, where, you have various, like, all walks of life taking all sorts of exams. And there would be some people who would instantaneously find out if they passed their nursing boards. And then there's all the doctors who are leaving, are like, oh my God, I have no idea how that went. I'm just glad it's done, and I won't find out for 6 weeks.
Yeah, well, that's what my son just went through, taking the MCAT. So he won't know for, I think, a few more weeks.
Right. Well, my win was, one of the things that I've been wanting to do is to be more present and try to play more with my kids, like actually playing. And there's a lot of times where they'll ask, like, can I play? Can I play? And I'm often like, no, I got to go do this. I got to do that. So this morning I stopped, and even if for 5 minutes, I built the Lego tower. It felt really good just to sit down and play for 5 minutes. And I think my son really appreciated that, even though I was literally in and out of there in 5 minutes, that I spent good time in there and built this tower. It's kind of like, one of those clinic visits that is only going to be like 3 or 4 minutes, but you made it feel like 30 and everybody's happy at the end. Total win.
Yeah, it's that it often, I love that. It's often not the amount of time, it's the investment during that amount of time, like, how are you fully there? And it's never enough, of course, never, but that's good. I love that.
But it was an awesome tower, so total win.
I didn't doubt that. All right.
See you next week.
All right, take care. If I can stop it. There it is.